Well, it's great to see you all, and it's a delight to be here. And I want to say thank you right off the bat to Shelley for organizing this event. As she was mentioning, I did this as a shorter thing in Victoria back in January. And I'm delighted to have Harjit, my colleague, here with me today so we can make more of a workshop, add more of a workshop to it, aspect to it this afternoon. So I just wanted to explain a little bit. Both Harjit and I are clinicians who work with the Ministry of Child and Family. I work with Saanich Child and Youth Mental Health, as well as a program called Project Alive for suicidal adolescents. Over in Victoria. I've been there for about 6.5 years now. Prior to that, I was working in Ottawa with the Mood and Anxiety, heading up the Mood and Anxiety Clinic there. And Harjit and I have known each other for some time now, and Harjit and I have also been working very closely because we both work with a group for kids who self-harm, which we will be talking to you more about today as one of the therapeutic interventions that we've developed, and some of the skills and approaches in that group are things that might be considered for yourselves when you're out there in your workplace trying to address issues with these kids. So the first part of the program, and I'll just review it quickly on the slide, is to talk about self-injury. What do we know about it? We have had some advances in our understanding of this problem, and I'm going to specifically focus on triaging and assessing these youth and going through some of the tools that are provided in your handout there today. We're going to kind of charge through the information in the morning, and the afternoon is going to be a lot looser in terms of interaction kind of stuff. And have more chance for us to interact directly with you. Harjit and I will kind of circulate in the groups that are going to be set up. We're only going to have a very brief lunch break, and I think it was a brown bag kind of lunch that we were requesting, only because we're very, very short of time for the stuff that we want to accomplish today. Then at the end, we're just going to sort of summarize and have a little bit more of an open discussion. So I'm just going to start off with this poem that one of the youths that I followed with for some time brought in her journal. A nice deep gash to change my pain. My heart hurts no more, solid as a rock. Scars lining my skin to forget my emotions. My pain inside shows on the outside. No tears in my eyes. Blood drops streak my skin. Those trusty scissors make me alive again. I'm wondering if anybody else has been exposed to clients who are this creative in terms of their poetry, or just generally speaking, their ability to express themselves on paper about some of this stuff. I see some nods in your head, and that's certainly something that is quite interesting for me to work with these kids. Is they can really express quite well in some respects what this kind of behavior means to them and what functions it fulfills. So let's make sure we know what we're talking about today, because that has been a bit of an issue in terms of doing some of the research in this area as well as understanding this behavior. So when we define non-suicidal self-injury, we're talking about the deliberate destruction of body tissue without conscious suicide intent. It's also not considered to be socially sanctioned, not acceptable within one's culture, and can occur in a broader range of non-suicidal self-harm behaviors, such as the overdosing, the minor overdosing that we see, and things like ingesting non-ingestible objects, which we've seen as well. So when we look at the mean age of onset, the age typically occurs between 12 and 15, and in some cases I think we're seeing younger and younger. There are some gender issues that we are trying to address, and in some of the studies that we've looked at, there seems to be equal incidence between males and females, whereas other studies, such as one I will talk a little bit further about, where the prevalence seems to be greater in females than males. That was a community-based prevalence study. One of the things we tend to know is that the females tend to cut and the males tend to hit and burn. These are the typical types of behaviors that we see: cutting, scratching, burning, self-hitting. In community samples, the majority will tend to do this kind of behavior maybe once or twice, but there is a small proportion, about just over a third of those, who might repeat and have multiple methods. Different types of locations on the body can be arms, hands, wrists, thighs, stomach. So this was a study we did that was published in the Canadian Medical Association Journal back in January 2008, and was based at UVic and supported by a CIHR grant. It is actually a longitudinal study that's going on, but this is a cross-section of the 2005 sample. Initially, when the study was started in 2003, they captured 664 youth, initially through a telephone screen, and participated in the first wave, and it was basically questions about healthy lifestyle choices and injury issues. In the second wave, we had an excellent retention rate. 580 youth responded to the second wave 2 years later, and in the self-report questionnaire, on the last 2 pages, we added self-harm questions. So in our sample, you can see of the total number in the 2005, we had a fairly even split between males and females. And what did we find in this study? We found that the mean age of onset for those who were self-injuring, lifetime prevalence that is, was 15.3 with an age range of 10 to 20. The mean duration was about 1 year and 3/4, of which just over 50% had stopped. And the question we generally asked was, have you ever harmed yourself in a way that was deliberate and not intended as a means to end your life? And you can see under yes, an N of 96, or 16.9%, basically 17% of youth within that age range had, at one point in time, had at least one episode of non-suicidal self-harm. We asked a broader question about it. It didn't just include self-cutting or self-injury. We also asked about ingesting non-ingestible objects as well as using medication in a non-therapeutic manner. And in this case, our female to male proportion was significant in that 3/4 of these youth who self-harmed were female. Sorry. Here's the question we asked, and of this group, the 83% were self-injurers or had self-injured at least once. But important to know, 31.5% had also ingested a substance in excess of the prescribed or generally recognized dose. In my work, it's typically Advil, Tylenol, mom's antidepressant medication, dad's antidepressant medication, something like that. Can be other things as well. So we asked them how frequently did they do this self-harm behavior, and it's sort of split, roughly a third, a third, a third, but slightly more in the more than 3 times. So you can see there is this sample of what I would call repetitive self-harmers in the community, and that is the particular population that I think that we are wanting to address. And I guess the message from this study is they're out there, and it's not necessarily a small number. When we asked them where did they get the idea, the majority by far seem to feel they got the idea themselves, although more and more we come to understand that these ideas come from elsewhere, including even family members, peers, influences in terms of movies, movie stars, things like that, having an influence.